Okay, let's dive right in. What we've got here is the high-yield, test-day decision logic for USMLE Step 2 CK Ophthalmology. We're going to master the vision loss triage algorithm together, turning these super complex clinical presentations into an immediate, reflex-like diagnosis for your exams. The board examiners, they're going to test your clinical decision logic on 9 primary complaints. You need to instantly recognize these: a kid with an eye deviation, an abnormal red reflex, sudden, painless monocular vision loss, transient vision loss that actually recovers, floaters with flashing lights, progressive visual field defects, hazy vision with a kind of red hue, night blindness, and finally, a diabetic patient with blurred or acute vision loss. Sounds like a lot, right? But our algorithm categorizes every single one of these. Let's break it down. First up, the pediatric branch of our algorithm, strabismus and leukocoria. The absolute critical task here is differentiating benign visual changes from life-threatening ones. So, strabismus, or ocular misalignment. This is highly tested. Screening happens at every well-child visit until age 5. Your test day clues? Look for a constant eye deviation at any age, or an intermittent deviation that persists after 4 months of age. You might also spot an abnormal cover test, asymmetric corneal light reflexes, asymmetric intensity of the red reflex, or even a kid presenting with torticollis, a head tilt.
Now, you might be wondering, why does early screening matter so much? Well, treatment outcomes are absolutely best when you start while the visual cortex is still malleable. Without intervention, these kids develop amblyopia, basically a functional reduction in visual acuity, and diplopia. Management means correcting any refractive errors with prescription glasses, strengthening that deviated eye by patching the unaffected eye, or using cycloplegic drops to blur the good eye, and of course, pursuing surgical correction if needed. But before you do any of this, there's one crucial diagnostic step you cannot skip. You absolutely have to look for the distinction of an absent or white reflex. This is known as leukocoria. While normal eyes have equal red reflections, a white reflex immediately, and I mean immediately, signals that a dilated fundoscopic exam is required. Never ever just write this off as a benign misalignment.
Because here's the thing, an absent red reflex could simply be a cataract, sure, but you must actively rule out retinoblastoma. This is a life-threatening intraocular mass. The key prognostic factor to burn into your brain is that optic nerve invasion is a primary predictor for metastatic disease. That right there is exactly why pediatric eye screening is an absolute must. Moving right along down our algorithm, we transition away from pediatrics and hit acute vascular occlusions. These are your sudden and painless loss emergencies in adults.
You've got to perfectly contrast central retinal artery occlusion with central retinal vein occlusion. If the question stem describes sudden, severe vision loss and the fundus is pale with a cherry red spot and temporal sparing, boom, select central retinal artery occlusion. Contrast this with central retinal vein occlusion, which is typically a bit less acute. It causes blurred vision, leading to severe loss, and shows optic disc edema along with retinal hemorrhages.
Okay, a massive buzzword you must link to retinal artery issues is amaurosis fugax. This is transient, painless, monocular vision loss that lasts for seconds to minutes, completely followed by recovery. It's often driven by thrombotic emboli released secondary to carotid artery atherosclerosis in older patients. Think of it as a huge warning sign.
The management urgency between these two vascular events? Drastically different. Central retinal artery occlusion is an absolute ophthalmologic emergency. To save the patient's vision, you must immediately perform ocular massage and utilize carbogen or hyperbaric oxygen therapy to reduce intraocular pressure and get that blood flowing again. Vein occlusion, on the other hand, leans more toward observation or, in some cases, an intravitreal injection of VEGF inhibitors.
You have got to recognize the classic blood and thunder appearance of a central retinal vein occlusion. We're talking about diffuse, scattered hemorrhages due to the backup of blood and increased resistance, which leads to ischemic damage. Notice the venous dilation, the tortuosity, cotton wool spots, and disc swelling. Seriously, lock this presentation in your brain for test day.
Next up, acute structural emergencies. This is the floaters and flashes branch where we differentiate between sudden structural emergencies inside the eye itself.
So, 2 major pathologies share similar early symptoms but look entirely different on exam: retinal detachment and vitreous hemorrhage. Retinal detachment features photopsia, those flashing lights, with floaters, leading to a progressive visual field defect that patients almost always describe as a curtain coming down. The fundus will show a marked elevation of the retina. Vitreous hemorrhage, however, presents with hazy vision or a red hue,
floaters, shadows, a decreased or absent red reflex, and crucially, an obscured view of the fundus due to floating red blood cell debris.
A really classic presentation here involves diabetic eye complications. If a diabetic patient has sudden vision loss, loss of fundus details, and floating debris with a dark red glow, you should immediately suspect vitreous hemorrhage. Remember the progression of diabetic eye disease for your exams. Hyperglycemic refractive blur will have a normal exam and actually improves with glycemic control. Cataracts present as lens opacity with a reduced red reflex. Glaucoma causes field loss or a painful red eye, depending on the type. But uncontrolled diabetes leads to retinopathy. First, it's non-proliferative with cotton wool spots, hemorrhages, and microaneurysms. Eventually, it becomes proliferative disease with neovascularization. It's those fragile new vessels that rupture and bleed into the vitreous or cause tractional retinal detachment.
Interventions depend directly on this structural diagnosis. Argon laser photocoagulation helps prevent those severe proliferative diabetic complications we just talked about. For an active vitreous hemorrhage, management requires bed rest with the head elevated and sometimes a vitrectomy. Retinal detachment? That requires definitive surgical correction, typically through retinopexy or a vitrectomy to literally reattach the retina.
Let's transition to the progressive and chronic diseases. This is the gradual visual decline branch of our clinical triage.
Let's apply this to retinitis pigmentosa. This is a progressive genetic mutation causing the loss of photoreceptors and retinal degeneration. Symptom onset usually starts anywhere from childhood, around age 10, straight through to early adulthood. The prognosis is, sadly, quite severe. Most patients are legally blind by age 40.
Your test date clues for retinitis pigmentosa are highly specific, so pay attention. Look for night blindness as an early indicator, followed by progressive peripheral visual field loss, specifically in the mid-periphery. Upon fundoscopic exam, you're going to see retinal vessel attenuation, optic disc pallor, and abnormal retinal pigmentation.
All right, let's bring it all together for a rapid test day summary. To ensure maximum retention before we finish up, let's do a quick callback and re-cement this whole algorithm.
Lock these connections in. Sudden painless loss with a cherry red spot? That means artery occlusion. Blurred vision with a blood and thunder fundus? Vein occlusion. Flashes, floaters, and a progressive curtain? Detachment. Sudden hazy vision in a diabetic with a dark red glow and debris? Vitreous hemorrhage. And in pediatrics, leukocoria demands an immediate fundoscopic exam to rule out the life-threatening retinoblastoma.
So here is the real question. When the exam clock is ticking, or when a real patient's vision is literally fading in front of you, will you trust your algorithmic decision logic to make the exact right call? By organizing these presentations systematically, you completely remove the guesswork. Master these branches, trust your triage algorithm, and go crush that exam.